Laminin-Alpha-2-related congenital muscular dystrophy is caused by mutations in the laminin-alpha-2 gene. It's either a complete or partial absence of laminin-alpha-2, and this is critical for the formation of these heterotrimeric proteins, laminin-211 or 221, and each of these numbers designates the chain. So wherever there's an alpha-2, that's where you're missing that alpha chain. So patients with this disease don't form either of these heterotrimers. Laminin-211 is found around the muscle fibers, and then 221 is concentrated at the neuromuscular and myotendinous junctions. So for those patients that have complete absence, they're missing the laminin isoforms at the neuromuscular as well as the myotendinous junctions, as well as across the rest of the fiber. Characterized by severe progressive muscle weakness from birth, and obviously hypertonia, so straight from birth, there's an issue. Delayed motor milestones, peripheral neuropathy, and changes in brain white matter is detected by MRI. The muscle disease, as Carsten mentioned, occurs during embryonic development. So when you see the disease, you automatically know that during development, muscle development, there have been problems that have been occurring during that developmental phase too. Now, during development, we have laminin-111, which is present, and that seems to be able to compensate at least partially for the absence of 211 during embryonic development, but then it goes away. We lose laminin-111 in our muscles, and now the predominant laminin is the adult form, laminin-211, which becomes predominant. And of course, patients with the mutation don't produce and switch to the adult form, and so there's none of these adult forms present. And currently, there's no treatment or cure, and everything is palliative. The treatment and care is palliative. So parents do an awesome job. So in terms of the molecular mechanisms, I'm an alpha-7 beta-1 integrin person, so I always put that, but laminin also interacts with dystroglycan, which is part of the dystrophin glycoprotein complex. And in this case, you see that in normal muscle, we have the adult forms of laminin. They bind to, in our case, the integrin and also dystroglycan. There's actually two binding sites, one for integrin and one for dystroglycan. And they attach to in this case, the alpha-7 beta-1 integrin or dystroglycan, and these are transmembrane linkage systems that link to the cell cytoskeleton. And so it forms a molecular glue that binds the outside of the cell to the inside of the cell, and therefore provides that structural integrity. So when you use your muscles, they're actually generating force against the matrix that's on the outside of the cell. So in laminin-alpha-2, you're missing laminin, and actually what you have also is a secondary absence of integrin in this case. We know that the integrin is also absent. So these two complexes go together, and when you're missing one, the other one is also missing. Dystrophin is still present, so there is some mechanism. Interesting, the integrin is missing. And integrin, we know, is really critical for cell communication, especially cell survival. So without the linkage to integrin, you're actually missing the AKT, which is a signaling pathway activation, and therefore you're missing that muscle cell survival. So when the matrix is present, muscle cells like to know that they've got a friendly matrix around it. It's sending signals into the cell that says, stay alive, grow, survive, everything is good. But when that integrin complex is missing, you miss those signals into the cell, and therefore the cell tends to not grow and tends to be much, much smaller than what it should be. I talked about laminin-111, which is the 111, and this is the target that we're using right now, although our cell lines could produce 211 as well if we needed to, and I'll talk about that in a second. So in this case, actually, alpha-7 beta-1 loves laminin-111. It's like its favorite matrix protein. It likes laminin-211, but actually likes 111 even better. And so when you put 111 into the system, it restores the laminin back, the integrin back onto the membrane, and you start these cell signaling pathways that promote cell growth and survival. So why use 111 versus 211? Patients are missing 211 from birth. And if you put 211 back in, what do you think is the major problem that the patient could face? An immune response, because they've never seen this protein before. And so if we use 211, the problem is the immune response could be triggered to target the 211 and clear it out. So it's called, it's basically an immune deficiency of the laminin. So the great thing about 111, laminin-111, although it's missing in the muscle, it's present in our kidneys and many other tissues. And so it's not recognized as foreign, right? So the key thing here is, can 111 really replace everything that 211 does? Why does our muscle in a normal situation or unaffected person like 211, and why is that important? And I might have some tricks, some ideas about why that is happening in a couple of slides. So that's the reason why we've chosen 111 over 211 at this point, although our cell lines could produce both. either or. So we could go either way. And especially if we, so if we use 211, we'll probably have to use some kind of immune suppression. So these are the first kind of experiments. They were done by a graduate student at the time, Jacinta Rooney, who's the lead author on this paper. She actually works with Carsten in Carsten's lab now, and so she's working there. And these were some experiments where we were taking mouse laminin, and so this is the mouse laminin, which is here, and she injected it. And what we were really interested at the time was what with the laminin, which is a big protein, would it just sort of like form in an area, and then you would get maybe some repair, because we're interested in muscle repair at that stage. And she came to the lab meeting and said, it's gone throughout the muscle. And I said, that's insane. Since 900 kilodalton protein, it's huge. That doesn't make sense. And so I told her to go back and repeat it. And she said, the next lab meeting, it had done the same thing. And so this is the result she had. So this is wild type muscle, which has Laminin-Alpha-2, the adult form. And it's missing in the mouse model that we're using here, the DYW mouse. And of course, we don't have any laminin-111 present in the muscle because it's missing in the adult. And then this is looking for laminin-alpha-1, and you can see that when she injected it, it went all the way around the muscle fibers. So it looks, a lot like this in terms of the distribution. And we use this as a control spectrum just to make sure that the muscle is good for immunofluorescence. And then she was able to follow the laminin from the tube. So this is the laminin in the tube, and it goes through the serum, and this is systemic delivery, and then ends up in the muscle tissue, which was really surprising to us. I mean, I didn't expect that to happen at all. So that was kind of the first set of experiments. So they give some history. And then, of course, we did a lot of experience looking at survival. So this is actually the Laminin-Alpha-2 knockout mouse. This is injected with just vehicle. This is injected with the laminin protein. So these are the same age. And you can see automatically there's a huge difference in how the mice look. And we have a video with this paper. So if you want to look at it. And then these mice, which the Laminin-Alpha-2 mice, this is their survival curves, die at very young age. When you treat with laminin-111, you can extend this out, and this is wild type at the top here. So we had a highly significant increase in survival in these animals. And this is a Laminin-Alpha-2 mouse now. Mice normally live about 2 years. So now we've got at 60 weeks of age. So we're over a year. So we've really substantially increased the time frame, their survival. So more recent studies we've done is to look at laminin after disease onset. So most patients are diagnosed, and this, yeah.
I have one question. We said, can you explain what you mean by wild type?
So wild type is like the unaffected. Okay.
And I had a question too. At what age did you apply?
Did we treat?
Yeah, what age?
Yeah, so these were treated all at about 10 days of age for a mouse. Okay, 10 to 12 days. So pretty young. So the big question is now, what if we treat later, right? Because most patients, most kids, have had the disease for a little while. So what happens? And this paper describes, this is actually done by Pamela, who was a graduate student in my lab and is now in Boston, the Boston Children's Hospital, in which she did injections of mouse laminin after the disease had already progressed. And what we found in that instance is that the laminin got to the muscle, just like we saw before, and it held the muscle at the current level. So when we look at what was happening, we were hoping it would reverse things and actually promote muscle repair and regenerate muscle. It stabilized the muscle. So it didn't get any worse, but it kind of kept it at that level, right? So the key thing behind this paper, which we published in 2020, was that the muscle got stabilized as in the current form, and it didn't get any worse. So that's the main thing. We're hoping it would get better, but I can talk about what the role that 111 may be playing in muscle repair in a second. So now this is human recombinant laminin. So we've got a cell line. It's transfected in with 3 constructs, each of the human chains, alpha-1, beta-1, gamma-1. And then, so we actually can do a Western blot and show that we have alpha-1 and beta-1, gamma-1, which are these chains are right close together. And this is a picture of our molecule. So it forms the typical cruciform shape right here. So this is actually it here. These are all the other molecules that are in there. And you can see it produces a nice cruciform shape. So we know we're producing the heterotrimeric protein from these cells transfected in, and we're producing a lot of it. So we have enough now, and actually for Haley in my lab, that's really great because she can actually have so much laminin now she can treat it. And the great thing is the laminin is really, we've got a purity thing. So the first major problem in this project was production and purification, and those were solved by Prothelia. So we got a really good cell line, produces a lot of laminin protein, and it's highly pure. So the purity is between 98% up to about 95% in each of the batches. And so this actually shows the purity, and it's mainly this guy here, this laminin heterotrimer, okay? So Haley has taken that protein and she's actually labeled it, and we can actually follow it as it goes into the mouse. So this is the mouse model for Laminin-Alpha-2, and this is him sitting on his back and then on his tummy. So we can actually see where the laminin is going after we inject. And this is the time after injection. So 30 minutes after injection, 1 hour. And you can see pretty rapidly, even 30 minutes, we're starting to see muscle localization of the laminin. We have this really hot spot here, which turns out to be the liver. So we know that clearance is occurring in the liver. And when Haley actually took the organs out and she could image them, so we know that a lot of protein gets trafficked to the liver, which is probably then getting degraded. But we get fairly rapid accumulation. And over time, 4 hours, you can see the muscles are really beginning to light up. And this is the bladder. So we also lose it through the kidneys. So this is kind of like part of drug development. We want to know where it's going and how it's being eliminated, and maybe how we can actually improve the retention of the laminin within the muscle. And this is where he's sitting on his tummy, and we're looking on his back, and you can see the muscles lighting up. And then you can actually see some of the kidneys beginning to light up here. So there is loss of the laminin, and this is 10 milligrams per kilogram. Interestingly, a mouse rapidly has a system that more rapidly clears drugs than humans. So that's one thing we have to know, that in humans it's probably going to be a slower process. So the laminin, Haley labeled the laminin with a fluorogram, and then was injected IV.
The question was, how was it injected? Just for everyone.
Yeah, so injected IV. So she injects, there's a vein in the back of the eye, and she injects right behind the eye and into the vein. So these guys were injected, how old were they injected, Haley?
4 weeks.
4 weeks of age, okay. And so then she actually took the muscle from this mouse and then looked a week later. So this is the diaphragm muscle, and you can see the human laminin in the diaphragm, the TA and the gastrocnemius muscle, and the vehicle treated didn't have anything. Okay, so that doesn't have anything. So it tracked pretty well and localized to the muscle. So this is the drug that would be used in patients once we get it to the appropriate purity, right? And that's an important thing. As I mentioned about satellite cell repair, so what happens in patients without laminin, in our normal muscles, we have these stem cells, and they can repair muscle. And in fact, in some dystrophies like Duchenne muscular dystrophy, those repair cells actually can repair for a while, and then they kind of exhaust themselves. But in Laminin-Alpha-2, they don't have this matrix. The matrix is really critical, and it kind of supports the repair of muscle. They don't have that, and so therefore they have a failure of muscle repair, which also contributes to the disease. So we wanted to look and see this environment. So what's happening? So we actually could isolate these myofibers. We can actually tease them apart, and then we can stain them for, and so we actually treated the mouse with either recombinant human laminin or 111 or recombinant human laminin 211. So now we're looking at the direct replacement versus what. So we wanted to try and tease out what could be different between the two laminins, and why are we going to miss something when we use 111 versus 211. So this actually shows the satellite cells, which are these guys here. We've marked them with PAC7, so you can actually see the satellite cells in both mice that have been treated. And then we looked at the laminin and its distribution around the satellite cell. So one big difference you notice is that 111 tends to cover. Okay, satellite cell is a repair cell. So it's a stem cell that helps repair muscle. Okay, all of our muscles. So when you go to work out, you damage your muscles a little bit when you're working out, you can actually repair your muscles with these stem cells. Divide and they repair the muscle, and the other satellite cell replaces the one that's just been used. So that's good, and that's what 211 does. In the case of 111, what we see is both cells go to repair the muscle, and we don't replace our satellite cells or our stem cells. And so eventually we would exhaust with 111 our stem cells. So that's a difference that we've noticed in our counts. So 111 seems to promote this repair and not replenishment. 211 repair and replenishment. So that's the difference we've found so far. There's the good and bad, right? There's the compromise that you've got to have sometimes. Yeah.
So that's basically why you're seeing stabilization and not regeneration.
You get stabilization. We do get regeneration, but we eventually exhaust that, is what we think would happen over time. Exactly. So yeah, we were hoping we would be able to completely regenerate the muscle again, but it looks like it kind of exhausts that possibility. That's probably why we have 211 in our muscle, at least one part of it, and not 111. That's why it kind of turns off. And the other thing could be a structural component, that 211 tends to be a lot stronger in its interactions with the matrix, and 111 may be a little bit more labile. It might be a little bit more for mobility of cells more than necessarily the structural component. That's why it's a stronger structural protein. It's like reinforcing your concrete, right? It's a reinforcing component. So the other thing that Haley has done now is we've used a new method called digital spatial profiling. This is a brand new technology that Haley has been using to actually look at simultaneously, how does laminin-111 in this case restore all of the parts of muscle? So with this technology, and she used not the transcriptome, but she used the antibodies, we can screen literally almost 100 antibodies simultaneously within a couple of days across the entire muscle. And so what she did here was she took the muscle, and actually where you see brown here is the laminin. It's been labeled with an antibody, and so we can actually see the brown staining around the muscle fibers. So again, the laminin is in the muscle, in the injected mouse. And then we use these morphological markers, Desmond, DNA, and these markers here to actually identify muscle versus like inflammatory cells and so forth. And then what we could do is then look at particular regions in the muscle to look at either inflammation regions or regions of what appears to be just normal, not normal muscle, but muscle that is intact, more intact muscle, and look at the expression of a whole range of different proteins at once, including signaling pathways like the survival signaling pathways that integrin activates on, immunological markers. And we can do this within one slide simultaneously. This technology is used in hospitals now to actually type cancer cells. So if you go in to want to have some kind of chemotherapy for a cancer, they actually do this to type the cells so that they know what type of chemotherapy to give you. We've adapted it now for doing in muscle. And we would like to get it, actually we're applying to NIH to try and get a muscle-specific panel, because these markers are for signaling pathways in survival, inflammation, and fibrosis mainly, which is the main components of the disease, but there are other muscle-specific markers we're going to look at. And so when she looked at this, the good thing about this is we can identify also biomarkers, which is the next critical thing that we need to do, especially going to critical clinical trials. These are just a few of them, but we saw that laminin-111 restored in the muscle using this technology many of the markers that are associated with metabolic changes that occur in muscle, so it restored it back to normal. Markers involved in cell survival, again, we would expect that. The AKT signaling pathways I mentioned should be restored. And so we get a lot of restoration of those markers pretty well. But some interesting markers that we didn't expect that changed. So this is the normal unaffected mouse. This is the diseased mouse without any treatment. And this is the mouse with treatment. And you can see laminin restored it pretty much back. And this is called P-junk, which is part of a pathway in muscle, restored it completely back to normal. And this is only with 48 hours treatment. So very rapidly, we restore the muscle back to its sort of homeostasis, its normal, much better state. We do get an increase in fibronectin in this case, but this is within 48 hours of treatment as well with the laminin treatment. So this paper is actually Haley's currently writing it, and so we're hoping to be able to get this information out. But it's a really rapid way to screen through and actually look at the effects of it. And we want to do this also with recombinant human laminin-111 too, and see what the differences are. So the great thing about the cell line, as I mentioned, we can produce 111, which is what we're going for now, or we could transfect in the laminin-alpha-2 and produce 211 and actually do a direct replacement therapy. In terms of like where we are now, I kind of want to talk about where we're going right now. We're optimizing the vehicle component for delivery. That's the big thing that's happening right now. And so that the next sort of big phase. And then we want to redo that, sort of do experiments in sort of larger animals to be able to scale this up so that we get towards patients. And then we also need to identify biomarkers. So it's really critical when we go into the clinic. So yeah.
Two questions. The first one was, how long can the satellite cells repair before they are depleted in the laminin-111 case?
So we don't know the answer. I don't know the answer to that yet. We're carrying on experiments with it. Yes, once the laminin is present, even if it's 111, it will begin the repair process, but it will exhaust over a period of time. We haven't done the direct comparison where, okay, if we look out over a longitudinal period of time, how long it takes to exhaust. So we don't know the answer to that question. That's a great question that needs to be answered.
Okay. The second question is, can you elaborate on what you're doing to optimize the vehicle for delivery? What contributes to optimal versus non-optimal?
Yeah, so I mean, it really depends. So in the mouse studies, with this current vehicle, this current solution it's dissolved in, if you like, we saw no negative outcomes, right? So literally thousands of mice have been injected. You know, they've been repeated by independent groups. So these studies have been independently verified, showing improvement of muscle force. So all of that has happened already, right? So we know this works, but we want to optimize it for human delivery, right? For human patients. So we want to make sure that it's going to be safe. And that's really the critical thing is I think, as Carsten would say, we would know that we want any therapy developed to be absolutely safe for the patient. It doesn't cause anything to be worse, right? That will be the worst thing. So the important thing is to optimize everything for patients.
Cool. We've got two more questions.
Okay.
Would Laminin-111 improve peripheral neuropathy or just muscle?
Perfect. That's a perfect question. We don't know the answer to that. I have a grant in with NIH to absolutely answer that question. And Haley has been beginning to inject into the cerebral spinal space because laminin doesn't cross the blood-brain barrier. It's too big a molecule. So she's begun experiments where she's injecting into the cerebral spinal space. So she starts in the sort of lumbar region injection, and she's got beautiful images, just like you saw with the mouse here. Oops. Showing the human laminin distributing up and down the spine and then out to the peripheral nerves. So we think that, we hope that will be a better delivery method since we can't get it into that space. It's kind of an immune privileged space, right? Although I think in mouse and patients, there is some leakiness in the blood-brain barrier, but laminin does not cross that. It's too big.
The next question is a combination of both laminins a possibility? I think they mean laminin-111 and 211.
And 211, it's definitely a possibility, yeah. I mean, it's always difficult when you're mixing drugs, and I think that Carsten and Anne probably could talk this. You have to optimize both and meet the FDA standards for injection. So it's always hard when you get multiple drug treatments because are we going to use how many milligrams of this per kilogram versus the other one, and how do we mix that together? So it's always difficult. Or do we use 111 and then switch to 211, like which naturally happens in your muscle during development? And that might be a cool strategy, actually. So, where you start with 111, get things going, and then switch to 211 so you preserve those satellite cells. Very great point, but we don't know the answer to it. Sorry. Something I would love to get funded to be able to do. So
maybe I have a question for you, Dean. So a lot of it is in the liver. So that's
yes,
is a great tissue to re-extract it from and see what its integrity is. Do you get the full heterotrimer out of liver or of any tissue?
I don't know. And that's something I think that Haley would want to look at, I think, to extract it out and see if we still got it or it's beginning to be degraded. And actually that's a method of, there is some in the heart too. So that we know we're targeting the heart tissue. So when she pulls the heart out, but the liver is the hottest organ there in terms of where the drug is. So you're right. Is it like a sink and it's sitting there and like being released over time, or is it actually being actively degraded through the liver as you go?
Yeah. Also, the interesting question is whether the entire full big heterotrimer actually gets to muscle in its full integrity.
Yeah.
Do we know
exactly.
That,
so it looks like from our Western studies, it looks like full length is there, but there are definitely some fragments. So you do get a breakdown. I think what happens is the mouse model, and probably in patients too, there's a lot of proteases in that matrix that break and remodel the matrix. And so what we've been able to show is that the laminas, you first go in, so they're like, you get the first dose, it starts to stabilize those proteases that are breaking down the matrix. And then with more doses, it gets more and more stable. So it takes a little bit of time to like stop the active degeneration of the matrix and the remodeling before.
Yeah, that gets me to my other question, which is a human translation question.
Yeah.
So in the human patient, we have, the mouse is a great model, but in the human patient, there's even more fibrosis and connective tissue in the muscle that you have to kind of get through.
Penetrate into,
to get to.
Yeah. We've been able to solve a lot of mouse muscular dystrophies over the years. Just look at the Duchenne story, right? There's a lot of mice that can be solved, but things didn't translate that well to humans. And so that's one of the things that and we've got some of the key research scientists here who are working on other approaches as well. Whether all of this, whether this one goes or the other ones, I think we just want to take the best thing forward as we move forward. Nothing's going to be simultaneously, unfortunately, developed. So you can pick and choose and say, okay, I'm going to go for a gene therapy approach or a linker approach or a protein therapy approach. That's going to be the thing, because we're not all at the same stage of development. And the question would be, okay, when we get to this point, then I think people like Carsten and Anne then have to kind of decide, okay, which looks like the most efficacious and the most safe to move forward. And I think safety is our primary goal here. We don't want to make things worse, right? That's the critical thing. So we want to make sure what we're doing is a safe approach that also shows efficacy as well. Yeah. Thank you.
Have you checked whether 211 can also restore?
So no, that's a great question. That's the next experiment we would I'd like Haley to do. So yeah, I've got again, the one thing you can really help was like contact NIH and say support funding for myristoyl deficient congenital muscular dystrophy. I mean, that's the big thing, because basic research, we get some funding from the companies, but their money is going all towards, production, safety testing and that sort of thing. They don't really have a lot of money to invest in basic research, but we need that at the same time. So, contact NIH and let them know that you need to have the work funded, because that's how myself and Dee, we get funded and able to do the basic research to bring to make sure that we understand the biology, because good science leads to good therapies, so that's important.
We have one probably last question. I think we have to then move on to the next presentation, but this is probably way too early. But if this will work, how many times do you expect you have to inject laminin into the patient?
So at the moment, it looks like on the initial testing, the area under the curve, which tells you about the dosing, is really good. So we can actually probably reduce it down. So these mice were getting 10 milligrams per kilogram per week. So but they metabolize the drug much faster than people. So we're hoping that we can get it down to, we don't know exactly what the dose is because that needs to be tested, but we're aiming for once a month would be an appropriate infusion time. But the longer the better. And we know that we can build laminin. It's almost like you could have a loading dose and then a maintenance dose. And the maintenance dose so loading dose to stop everything and hold it where it is, and then a maintenance dose, which could be once a month or once every few months. It's possible, yeah. So then maybe you might be able to get it injectable at home. So actually, Haley's done lots of different ways of routes of administration, and she did sub-Q. So that was one of the things that she's done. So there are some routes that are not that great, and there's some for delivery, and there's some routes that are really, really good, right? So yeah, we're hoping we maintain, once we get the maintenance dose, it's going to be less frequent, and then we're just going to maintain. The matrix, once it's there and stabilized, it's pretty stable for a period of time before it goes over. But we don't know exactly the time point. Okay?
Thank you, Dean.
You're welcome.